We have 2 left in the session for today. The first of those is going to be presented from the Medical College of Wisconsin by Arvind Srinivasan, who is a fourth-year medical student and talking about a single center 8-year experience of segmental artery mediolysis management.
Thank you for the opportunity to present our research today. My name is Arvind Srinivasan, representing the Medical College of Wisconsin in Milwaukee, Wisconsin. I will be presenting a single center 8-year experience of segmental arterial mediolysis management. We have no disclosures or conflicts of interest to declare. So to begin with some background information, segmental arterial mediolysis, or SAM, is a rare and poorly understood vascular disorder. It is non-inflammatory and non-atherosclerotic, which sets it apart from other vascular disorders, although it can often occur in conjunction with atherosclerosis. SAM generally manifests as degeneration, specifically vacuolization of the medial arterial layer. It most frequently affects the visceral or the renal arteries, but it can occasionally involve extra-abdominal vessels as well. Historically, SAM has been diagnosed with histopathology. The lesions can be visualized under the microscope, and this is still the gold standard for confirmatory diagnosis. However, most cases of SAM are actually diagnosed radiologically via CT imaging and correlated clinically. The histopathological diagnosis is less common. SAM can also present with a variety of clinical symptoms, ranging from clinical silence to vessel rupture and organ ischemia. The degree of intervention typically depends on how the patient presents. If they are asymptomatic or have clinically mild disease, then they can be managed conservatively with operative intervention if they present acutely. So our objectives: there are currently no established therapeutic or monitoring guidelines for SAM. So we aim to describe a cohort of patients at our institution who were diagnosed, describe their natural history, as well as their outcomes in the hopes that this may guide future management. We also aim to describe the medical management options that were used, as well as identify patients and presentations that could benefit from open surgical or endovascular treatment. For our methods, we conducted a single-center retrospective review of patients diagnosed with SAM at our institution between the years 2011 and 2019. Patients were included on the basis of radiologic diagnosis, and we collected demographic factors including past medical history, presenting symptoms, affected vasculature, and how the patients were managed, and then compared this between patients who underwent surgery and those who were managed non-operatively. Shown here are some of our demographic factors. Out of 30 patients total, 27 received non-operative management, while 3 presented emergently and required surgical intervention. 2 patients presented with mesenteric ischemia and 1 with a ruptured pseudoaneurysm. The majority of our patients were male, and the mean age was 53.5 years with a range of 35 to 72. Hypertension and hyperlipidemia were the most common comorbidities, with tobacco use being third most common. This is a breakdown of the patients who presented requiring surgery. 2 patients had mesenteric ischemia, 1 acute and 1 chronic. The third patient presented with a ruptured hepatic artery pseudoaneurysm. The latter 2 patients were managed via endovascular approach, while the patient with acute mesenteric ischemia was treated via thrombectomy and patch angioplasty of the superior mesenteric artery. For patient presentations, 6 of our patients were referred to the vascular surgery clinic via incidental findings on CT imaging, but were otherwise asymptomatic. Otherwise, abdominal pain was the most common presenting symptom and was present in every single patient who presented symptomatically. All patients were diagnosed radiologically. The celiac axis was the most commonly involved visceral artery, with the SMA being second most common. 9 of our patients presented with SAM lesions involving multiple major arteries. Dissection was the most common imaging finding initially, followed by pseudoaneurysm. Here's an overview of our results. Patients that were managed non-operatively most often had some combination of antihypertensive, antiplatelet, and lipid-lowering therapy. 7 patients received all 3 of these after their SAM diagnosis. 17 patients were started on antiplatelet therapy, with 13 patients started on antihypertensives after diagnosis. We also obtained serial imaging on all of our patients, and 6 of these patients experienced lesion resolution on surveillance imaging after their initial diagnosis, with an average time to resolution of 325 days after diagnosis. Furthermore, all patients who were managed non-operatively reported symptom cessation at further visits. Here's a deeper look into our antihypertensive management options. ACE inhibitors and angiotensin receptor blockers are most commonly prescribed as the initial antihypertensive therapy. Beta blockers are second most common. We believe that these options were the first choices due to their favorable cardioprotective effects, relatively well-tolerated side effect profile, as well as ease of adjustment at further follow-up. Our antiplatelet and statin management follows a similar pattern to the antihypertensives. As we might expect, aspirin monotherapy was the most common option for patients upon hospital discharge, with clopidogrel supplementation if there were indications for dual antiplatelet therapy. It's also likely that provider preference played a role here, as aspirin is very routinely prescribed, easily accessible to patients, and is efficacious. Statins also follow much the same logic. They are routinely prescribed in order to decrease cardiovascular risk factors. For our post-hospital surveillance strategy, we tended to have patients follow up approximately 2 weeks after discharge with follow-up imaging at the 60-day mark. If there was no indication of lesion progression, then follow-up visits were spaced out to approximately 6-month intervals. For patients whose lesions resolved completely, follow-up visits were no longer deemed necessary and then were no longer required. Additionally, all of our non-operative patients reported symptom cessation without recurrence, and several patients experienced lesion resolution on follow-up imaging, as mentioned earlier. So in summary, our non-operative management included the triple combination of antihypertensives, antiplatelet, and lipid-lowering therapy. Patients under surveillance had lesion resolution within 1 year, while patients who required operative intervention presented with mesenteric ischemia and pseudoaneurysm rupture. So limitations of our study included the fact that it was a single-center retrospective study. There's also the issue of overlapping medication management. Many patients presented to the hospital while already taking some of the medications that we mentioned earlier. There were also only 3 operative patients, so those results may not be generalizable. As for conclusions, patients who presented to our institution with SAM did not undergo surgical management unless they presented emergency with rupture or mesenteric ischemia. The optimal non-operative management is not standardized, but is targeted at cardiovascular risk factors, and the majority of patients were managed non-operatively. Patients who presented in extremis require emergent revascularization and hemorrhage control, and lesion resolution can occur on surveillance imaging. So we would like to thank the Medical College of Wisconsin and the Vascular and Endovascular Surgical Society here for having us today. Thank you all for your time, and I will take some questions.
Well, thank you very much. I know that your mentor is also on with this call as well, so that if there's a question that comes up, that both of you can help us answer that. So the first question is from Dr. Velasquez, and her comment was, "This was a very nice review of this rare pathology. I find it to be mostly a diagnosis of exclusion. Any data on using systemic anticoagulation agents on those with radiographic high-grade stenosis or near occlusion of visceral vessels when they don't have ischemia yet?"
Thank you for the question. I would like to defer that one to Dr. Mansukhani, if that's okay.
Sure. At least in our patient cohort, there was no patients that had high-grade stenosis of any of the visceral vessels. Most of the time, it was just vacuolization or small focal lesions without stenotic components to it. The patients that presented with mesenteric ischemia, what I anticipate happening was there was a vacuolization or a small focal dissection that presented to become flow limiting. So none of those patients were managed non-operatively.
And maybe you can clarify this for me, because This is not a diagnosis that I have particularly seen in my practice. And what you described was arteries that have that presented as an incidental finding of dissection. But there are other characteristics radiographically that make this more consistent with SAM than just something like isolated mesenteric artery dissection?
Yeah, that's a good question. So my understanding is that you will see like the segmental lesions are pretty characteristic, meaning that they're, multiple and generally non-contiguous with one another as kind of a hallmark of the pathology. And apart from that, it is basically just a clinical correlation. Biopsying a visceral artery is, very invasive and difficult to do. So if it kind of fits the picture and there isn't really a better explanation for why a patient experienced, a spontaneous dissection, and it looks to have resolved itself on an incidental imaging finding later on down the road, that's when SAM would kind of creep higher up the differential diagnosis.
The other thing that you mentioned is that the incidental findings were occasionally pseudoaneurysm, was also saying that, the celiac artery was most commonly involved. Was there one artery that was more commonly seen to have pseudoaneurysms versus dissection, or just kind of both of those vessels, and those are the two main things to look for in addition to the vacuolization?
Kind of more in line with the latter of those two possibilities. We didn't really break down which arteries had specific findings in this presentation. It's definitely something that we'll dig into a little bit more.
There's a question from Dr. Taubman. Given that the non-operative management included individuals who were already optimized on cardiovascular medications, do you have a recommendation for any surveillance measures and intervals once they're on those medications?
That's an excellent question. I think Dr. Mansukhani, if you could handle that.
The best recommendation we can provide is just what we do in our clinical practice, which is a short interval follow-up with a follow-up CT angiogram within a month of presentation, and then 3 months and 6 months, similar to an aortic dissection that you're worried about monitoring closely.
And then Dr. Corrier, our president, wants to know if there was anything you learned from this analysis regarding surveillance for asymptomatic patients. You talked a little bit about how often, but do you always have to use CT?
Because these lesions are so focal, it's near impossible to see them and characterize them consistently with ultrasound. That's why we've used CT in the past. But the overwhelming lesson that we learned from this is that if a patient presents with a lesion that's characteristic of SAM and they don't need intervention immediately, then they're not going to in the long term.
And then we have one last question from Kelly Kempe asking about before the 3 emergently patients presented, were you following them beforehand? Were these patients on your radar, and any clue that they would have this thrombosis or rupture?
So that's actually a very good question. The one patient that presented with chronic mesenteric ischemia was being followed previously. The other 2 were not. The patient that had a hepatic artery pseudoaneurysm was a transfer from an outside hospital after they had attempted management. And then the patient with acute mesenteric ischemia presented to the emergency department pretty much that day.
Well, I think that was a very nice talk about something we don't see very often. So something for us to all keep in mind.